Good afternoon. Welcome to Yale Department of Radiology Grand Rounds. If you have any questions, please feel free to type them into the Q&A section of the Zoom meeting. I'm delighted to introduce our speaker today, my friend and colleague, Dr. Lea Azour. Lea is a native Californian who came to the East Coast to attend college at Yale, graduating with a degree in psychology. And it's only fitting that her last stop on the East Coast before heading back to Los Angeles, where she has recently accepted a faculty position as Associate Professor of Radiological Sciences at UCLA, is at Yale again. Welcome back. Lea earned her medical degree at New York Medical College and completed her radiology residency and fellowship at Mount Sinai School of Medicine in New York. Until last week, Lea was on faculty at NYU, where she served as Associate Section Head of Thoracic Imaging and the Director of Wellness for the entire Department of Radiology, and completed the Stanford Physician Wellbeing Director course. She has an exceptional track record of leadership and service, both at NYU and within the National Radiologic Association societies. She was chair of the Junior Faculty Committee and a member of the Resident Recruitment Committee, the Residency Program Evaluation Committee, and the Women's Leadership Initiative at NYU. I'm just listing a tiny fraction of all of the wonderful work that Lea has done. She's an associate editor for the cardiothoracic imaging for ACR's RAD exam, the thoracic section leader for the core exam review course for the New York Röntgen Ray Society, and the chair of the Health and Wellness Committee at STR. She's an associate editor of the Journal of Computer-Assisted Tomography and a peer reviewer for numerous other journals. Lea is a master educator with extensive teaching experience with medical students, residents, and fellows at NYU and beyond, through the New York Röntgen Ray Society and other societies. Perhaps her year of teaching second grade after college helped her find her passion for teaching. In 2019, Dr. Azour received the STR seed grant studying machine learning-based reconstruction from CT sinogram data to achieve radiation dose reduction, something I have to learn more about. She is a co-investigator currently on 2 grants studying survivors of COVID-19 and novel treatments of stage 3 and 4 non-small cell lung cancer. Her research and educational efforts have led to numerous publications in peer-reviewed journals and book chapters. I will not start listing them or we will not have enough time. Amy?
Hi, I just wanted to say a few words. So normally our speakers get one person introducing them, but because our speaker today is doubly amazing, she gets 2 introductions. So besides being an amazing colleague and incredible cardiothoracic radiologist, Lea has also become a leader in the field, in the area of wellness. As Anna mentioned, she was head of wellness for the entire Department of Radiology at NYU, which is one of the largest academic departments in the country. She also is chair of the now standing Permanent Society of Thoracic Radiology Health and Wellness Committee. She's the chair of that. She ran the she helped run, or basically ran, the wellness symposium at Society of Thoracic Radiology this past year, which I heard was incredible. And not only that, ARRS had their first ever wellness symposium just couple weeks ago in Hawaii, that our invited speaker was one of the leaders with this entire symposium. So, and again, just as amazing as she is a cardiothoracic radiologist, the area of wellness, health and wellness is so important, because you can't be your best person, you know, in your personal life, or the best doctor that you can be if you're not well. So that is just as important, or if not more important, than all of her amazing academic accomplishments. So we're so excited to have you here, and it's an absolute pleasure. So welcome, Lea.
Hi, everybody. I am so excited to be here. Thank you for the invitation and the wonderful introduction. It was more than doubly better than any introduction I've ever had to date. So it is nice to return here to New Haven. And when I was here, I was a psych major and I worked a lot with children's well-being. And so I feel like I've come full circle as I've aged now working on adult and faculty well-being, which is wonderful. But today I am not wearing my wellness hat. I'm wearing my cardiothoracic radiology hat. And we're going to talk about lowering the magnetic field strength of MRI as an ends to improve well-being in healthcare and really improve the care we're able to deliver and raise the bar in terms of what we can push MRI to do for our patients. So there are two main objectives today. So pretty basic. The first half, why low field? Why are we even talking about this? What's the rationale and what's the mechanism in general? Beyond the lung, just in general. And second, what do we know? Current knowledge of low field MRI, and then taking a specific look at low field in the lung. And finally, we'll wrap up very briefly in the last few slides, looking at the broader landscape and future directions for what this technology can hopefully bring to our patients and healthcare. So what's low field MRI? Typically, it is anything that's less than 1 Tesla in field strength. So this is a logarithmic chart, and we see that we do have machines that can clinically acquire images from sub-Tesla levels up to our ultra-high field of 11.7 Tesla. There has been steep growth in low field MRI, and we see this really took off around 2017, 2018, where we see this trend line of increasing results per PubMed citations. But of course, everything is scalable. So it's only about 6 results per 100,000 citations right now. And that's for low field MR, portable MR, and less for 0.55 Tesla MR, which is what we used at Yale and the version that's being rolled out at many academic medical centers. So let's put this in scale. It's about 1,000 times less in magnitude, the COVID citations, of course, but the trend line for low field is not expected to precipitously decline as it has done for COVID. So amidst this increase, in the past 2 years, a headline came about: low field MRI, its history and renaissance. A renaissance implies that something existed that was worth it, that's worth bringing back. So what existed in the days of yore in MRI? This is an image that was in Radiology in 1982, so about 40 years ago, and it was a study that imaged patients, imaged dogs, patients with cancer, and they did a variety of things. They did ECG gating, they injected a variety of substances into the animals, and we can appreciate on this magnet 40 years ago at 0.15 Tesla, there is a hyperintense right hilar melanoma metastasis. So even 40 years ago, low field was showing us something. Most of the growth since then, and most rapidly, was in neuroimaging. So let's take a walk back very briefly, only 1 slide's duration worth of the historical perspective. Where we are today is over 100 years in the making. So in 1882, Nikola Tesla described the magnetic field, and this is him. And I think this picture is a little poetic in its lung-like appearance, so fitting for our talk. And in 1937, Isidore Rabi developed NMR. So he developed a way to measure the movement of nuclei. And this happened at Columbia University. He was a physicist. And then a physician came on the scene in 1971. So Rabi got a Nobel Prize in 1944. In 1971, Raymond Damadian, he was in New York too. So most of these names were in New York. He said, well, cancer has greater T2 signal than healthy tissue. What if we could measure the radio waves? And he filed a patent and he started constructing a machine based on this idea. Near around the same time, Lauterbur, a chemist in New York, he started imaging vials of water. And he created images of these vials of water. Then he moved on to clams and then peppers. And he proved that, yes, you can create images out of this. But what really pushed this was the first fast MRI technique, echoplanar imaging, which made it so that you could actually get images in a reasonable time frame. And what do I mean by reasonable time frame? This was indomitable. This was the physician's creation. So he filed a patent and then he made the machine. He built this huge scanner. The scanner was 0.5 Tesla. It was low field. It ran on a lot of helium. He was losing liters of helium because it was a leaky design. And when you lose liters of helium, you're losing a lot of money. So it was expensive. Not only that, it was not very efficient. Scan took 5 hours. And it also relied on body habitus. He tried to scan himself first, and he didn't get great images. A week later, this is his assistant. His assistant, who was skinnier, realized that nothing terrible happened to him from going in the magnet. And then they generated this image. So not bad, I guess, for a 5-hour scan, image through the chest, but clearly 40 years later, we have developed improvements. And what has happened what have we done to improve image quality? So namely, 3-pronged approach, hardware. Our magnets are better, our gradients are better, coils, transmitters, receivers. We have better sequences. We have sparsity in our imaging. And we have post-processing, and hopefully AI can help us achieve the high performance that maybe our hardware is not getting us to. So a few slides will be spent on briefly looking at these factors that increase our image quality in MR. This is the Larmor equation. So omega, this is the precession of the nuclei, gamma is a constant, and B is the field strength. So you have increasing signal to noise with increasing field strength. So let's use an example. Most of our magnets are probably around 1.5 Tesla. The SNR of a 1.5 Tesla magnet is almost 5 times that of our low field system. So if we're going to talk about rolling out this low field system, we have to generate enough signal to make it worth it, to make it valuable to us. The other thing that's important in addition to signal is time, how fast we get to that maximum gradient strength. And this impacts our scan time, and this also depends on our hardware. And then the most exciting part and what has really accelerated MRI and our capabilities are things like parallel imaging and compressed sensing, this undersampling that allows us to scan more quickly, but does have a lot of computational requirements, for example, compressed sensing. Then we get to machine learning and denoising, and these can be employed in different domains, the imaging acquisition domain or post-processing, to fill in the gaps that the machine basically intuits are there. So why the Renaissance? So we saw that first image from 40 years ago. It wasn't that great, but clearly there is an imperative, be it moral, business, for us to have lower field MRI. And what is that? So I'm going to quote Wald, who said, "Low field is part of the push to jailbreak MRI from its centralized location in healthcare and allow it to reach larger patient populations and achieve new uses." So when we think about our MR scanners that we have in our hospitals, they're usually centralized, a one-stop shop to image various body parts. Not only are they centralized, but they may be entrenched. They're heavy, 3T magnets, almost 17,000 pounds. They require helium, 200 or so liters, I think. So quench pipes, they require rooms to be specially configured. So sighting them is quite difficult. They need sighting accounting for acoustic shielding, magnetic shielding for fringe fields, and also the radio frequency shielding. So all of these factors are limiting the healthcare that we can also provide, because we can't sight these or get these machines out or resources out to patients. So we also need to jailbreak basically out of the constraints that the machine and our current technology has given us. And hopefully then we can see more benefits. So now, what are the advantages and challenges with the 0.55 Tesla? So this is the 0.55 Tesla magnet at NYU. It was a 1.5 Symptom magnet, Siemens magnet that we modified to perform at 0.55 Tesla. So there are low field magnets that are unmodified, and typically these are lower in initial cost, and they have lower operational costs. And this is because they can be without helium. So these magnets may not require any helium at all. And because they are lower field strength, they have different sighting requirements in terms of shielding the room. And more interestingly, there have been developments in artificial intelligence-based post-processing so that even if you have this electromagnetic interference from your room, you can subtract it out. So you may not even need physical shielding anymore for some of the extra interference you get because we can fix that with machines, which that is a great cost lowering ability. Portability and open design. This goes to patient comfort and it goes to the potential for moving our imaging from this episodic care to continuous care or point of care imaging, which I think is what a lot of people are talking about right now and bringing imaging to the consumer level. Then we have lower energy deposition in tissue. So you can move your procedures from being CT guided perhaps to having things be MR guided if you have lower SAR. You can image patients with devices. And then artifact reduction. And as we discussed, the potential limitations are the lower SNR, longer acquisition times. I mean, is that really where we want to be going? You're taking longer for scans? Probably not in the age where we're trying to increase throughput and increase access. But the thought is that all of the other tools we have at our disposal now in 2023 can bridge that gap. So why the Renaissance? Two major things, the two A's, accessibility and applicability. So we're going to look at some of the geographic and socioeconomic disparities. The scanners have to be available. They have to be physically sited. Even if you have them, patients need access. And when we think about patient access for MRI, that means devices within the patient. They have to comply with instructions. And when we talk about lung imaging, are these breath holds for these patients who are sick with lung diseases? Is this hyperpolarized gas? We want things to be easy and fast. And really to do that, that would be free breathing, that would be room air, oxygen at most. It would be quick sequences that maybe they're not perfect, but guess what? You can have AI make it perfect retrospectively. And then applicability. And this is when we talk about using it for different use cases. So MRI has taken off in all the body parts, I think, except the chest. When you think about MSK imaging, predominantly MRI, neuroimaging, MRI, abdomen, MRI, and I think the lungs are lagging behind. So this technology hopefully can help us move lung imaging to where the rest of the body has already reached. And the goal would be to improve the quality of the patient care we're delivering, of course. So what's the first access hurdle? That's cost. And I am not a business administrator, so I'm not sure if what is cited in the literature is accurate, but the estimates are about it's 1 million per Tesla for your magnets. And most sales of magnets in the United States are 1.5 Tesla. And abroad, for example, in Asia, they have more lower field magnets than we do here. It's a balance between these higher Tesla machines or having more machines. This is the availability globally of MR units per million population. Japan has the most, United States is not far behind, but of course, the global availability isn't immune to regional disparities or regional scarcity. And the thing with this graph, there are a lot of major countries on this graph, but there are also a lot of places that are not listed on this graph that were cropped out because they have less than 20 MRs per million people. So big countries, France, Mexico, Israel. So these major places don't have enough scanners. And why is scanner density important? Because it correlates with life expectancy. This red box is an area of unmet need. So the red box corresponds to where there are less scanners per capita in comparison to the global scanner density. Now, of course, scanner density is one factor that relates to these unmet needs, but there are other demographic factors that imply life expectancy or associate with it. Things like internet availability and overall life expectancy as well. The greatest unmet need probably and one of the biggest drivers of mortality and morbidity is cancer, which from 2018 to 2030, we expect there will be 40% more cancer deaths. Imaging, of course, is crucial to our cancer care. So juxtaposing high-income countries on the left to low-income countries, let's look at the disparity in MRI availability. So we can look at the means or the medians. So the mean is 27 MRIs in high-income countries per million persons. In low-income countries, it's less than 1 MRI per million people. Less than 1. So this really shows us where we are with MRI. It's way too expensive. We haven't driven down the cost. It's not intellectually accessible. Are there technologists or physicians available to interpret it in these low-income locations? Now, scaling up imaging. So the prior chart was from this article that was a Lancet Oncology Commission, and this is their graphical representation of the return on investment for scaling up imaging and increasing resources. So one would think that the return on investment would maybe be only for these low-income countries. So we see a huge ROI for South America, but guess what? The United States also has a huge ROI, as do other developed countries, Canada, other parts of South America, Africa, Australia. So scaling up our resources really just scales it up for everyone at the same time. MRI utilization is the second thing. So you may have the resource, but how are you using your resource? This is admittedly a little old from 2016 and 2017, but the reason I show it is to show the location where patients are getting scanned. And what's striking is that the majority of MRI scans are performed in non-hospital locations. And I think this speaks a little bit to what patients want, which is not so different from what workers and faculty want. They want flexibility in where they're going to get scanned, when they're going to get scanned. It needs to be easily accessible. And if it's easily accessible, it's always this tension between overutilization and cost. So Andy Rosenkrantz and Rich Duzak, they wrote about the advanced imaging utilization, CT and MR, and cost savings in accountable care organizations. And they found there was only one significant finding in this study, and it was increased MR utilization was associated with significantly less, a small amount, but still significant, less cost. And they hypothesized that this was due to favorable downstream imaging utilization and favorable outcomes for these patients, perhaps because of earlier diagnosis or more efficient diagnosis. So we know that not only is there a tension between the cost and availability, but also the faster exams and the better images. I think we've reached a point with our technology that they don't have to be at the expense of each other, but they can move hopefully in tandem. So increase the speed of the exams and also get better images at the same time. So now that we've kind of set the stage for low field MRI and described it in a general sense, we'll spend the next half discussing thoracic MRI more specifically and some of the work we did at NYU looking at lung MR in a cohort of about 100 or so patients. This is a Fleischner Society paper on the state of thoracic MRI. It came out almost 3 years ago. And as we noticed, there are several indications and lung pathologies, but data support current clinical application for only a few. And those include cystic fibrosis, lung cancer staging, nodule characterization, and pulmonary hypertension. Even if data does support it, I think we'd all be hard pressed to find academic medical centers that are routinely doing MRIs of the lungs for lung nodule characterization. So we're not even there. I think mediastinal MRI is probably not even there in most cases. We're there with cardiac, but we haven't really moved beyond that into mediastinum or lungs. Further evaluation, we're not really there for PE either, which is a huge indication, and then investigational, asthma, ILD. And so the work that I've worked on, the realm, has kind of been in this pulmonary parenchymal abnormalities with an investigational magnet. So why has it taken so long? What's been the pause with lung MRI? This is one of our low field images of the lung. And that's because lung is fundamentally different than other organs. It has low proton density, and that means the amount of signal we're going to get from those MR images is lower because signal is proportional to proton density. So what have the strategies been that people have tried to use? Hyperpolarized gas, but that's expensive. I'm not sure if there's a business case for it. It's still investigational. UTE or zero echo time sequences, which help us increase that signal, and low field strength. So low field strength, because of the T1 and T2 relaxation times, they are associated with increased signal and also lower susceptibility artifacts. So the T2 star is longer, and the lung has a lot of air tissue interfaces. So there's susceptibility at all of those interfaces. With less artifact, you can imagine with the lung, how much at all of these, with less susceptibility, how much less artifact you'll have. These are examples of UTE images. These are from a higher Tesla magnet. Also, UTE sequences can be effectively achieved on low field systems. The MR image is on the far left. It's very, very similar to the CT images. So we are getting there. And this is from the Fleischner Society paper. So this is the lung nodule indication. This is the ILD. The MR is on the left. So not bad. We're getting there. Are there still limitations? Of course there are limitations. We all know how a CT is acquired. Full inspiration, 1 breath hold, 20 seconds. What about the MR? I'll tell you about our sequence in a few minutes and get into the differences. So low field made its arrival in 2019. So we were 2019 was COVID, wasn't it? We were 6 months into COVID, and then Adrian Campbell Washburn from the NIH comes out with this great radiology article where they image different organs with the low field system. It really harkened back to that 1982 radiology article where they imaged different parts of the body with their first magnet. So this is patient A on the left, patient B on the right. And what she did and her team did, they looked at the T1 and T2 times. They saw, how is this technology amenable to fast MRI techniques? They even did image-guided cardiac caths, and they measured the heat that was generated on these devices. And so several benefits were pointed out by this study, some of which we've already gone over. And this includes the increased lung signal. We can make out the cystic lung disease much better on the 0.55 Tesla than the 1.5 Tesla, so the same patient. Improved field homogeneity. And then some places do give inhaled oxygen because that increases the signal enhancement of the lung. So that can also help us visualize lung parenchyma oxygen. Now, this is our low field scanner, our low field image. So it's a video. I don't know if I can't scroll it. I'll play it again. So we see sparing. This is normal parenchyma. I don't know if it projects blurry for you, but this was a post-COVID patient. So what happened was we had COVID in March. We got a scanner around the same time. The scanner is investigational, and we need willing patients. We had many COVID patients at NYU, and many of which who were highly motivated to figure out why they had long COVID. So these patients were coming to the pulmonology clinics and they wanted help. They wanted to know why they were having their symptoms. So we thought, well, we could marry these two aims. We could image this population, imaging would be one prong, and then a registry was started, which included a multidisciplinary team where they had multiple assessments from rehab, neurology, rheumatology, et cetera. Of course, all of the patients didn't want to get MRIs, but many of them did, and many of them got repeat MRIs. And at the end, we had over 200 MRIs with which we could interrogate, develop better sequences, optimize UTE and isotropic sequences from this great patient population. So we had this population, we had all these scans. It's now, we started scanning in September of 2020. September 2021, it's a year into our scanning. We decided to assess what's happening. Is this worth it? It's a resource. This was not funded at that time. So all that scanner time was donated basically by the department. So what have we found? Do we keep going? Do we not keep going? And we had three main objectives. If anything is going to be worthwhile, it has to have some sort of comparison to the gold standard. How does this compare to CT? Is what we're seeing even relevant? Second, now what about if you only have an MR? You don't even get the CT. Is there a clinical implication? Is there clinical relevance to the finding? And then finally, dynamic imaging. So we can do ventilation perfusion on low field scanners. This is all non-contrast. This is all free breathing. We can do, we can look at respiratory patterns. There's so much we can do with dynamic imaging. So that was our third prong. So the first thing we did, intermodality concordance. Out of the 106 patients that we had scanned within the first year, only 22 of them had CT and MRI within 30 days. And of course, if anyone's going to look at your cohort, they're going to say, well, how are you comparing an MRI and a CT that's 6 months apart? So we restricted it to 30 days. These two images were, I believe, 6 days apart, and we can make out the ground glass opacity very well in the left upper lobe. I think it's probably even more conspicuous. It may be my windowing. But again, these are acquired in a different way, 30 seconds versus 5 minutes. So the T2 blade sequence took us 5 minutes to acquire. It was during free breathing on room air. On the left, a CT is 1 millimeter slice thickness. If we reduce the slice thickness, we reduce our signal intensity. So that's the trade-off, right? So I kept asking, well, hey, let's push it down to 3. And they kept saying, we can't yet. It's not going to work. So we started with 6 millimeter. We went down to 5 millimeter. And that was really as low as we got in that first year. So this is 5 millimeter. The other thing is full inspiration. You have an increased AP diameter of the chest. If you're free breathing, your lung volume is going to be lower. And also over the course of 5 minutes, you're laying down flat on your back. So I think the chest imagers know that if you have dependent atelectasis and you're worried about fibrosis in a post-COVID or any cohort, that's going to be kind of a tough thing now because you're having someone lay down for 5 minutes and you're going to have a level of dependent, what I'm calling ground glass, but it's really increased signal intensity at the lung bases. So I will say probably ground glass was overcalled. There was no prone imaging here. There was no, troubleshooting or investigation. So we looked at several things: the presence of opacity, extent, distribution, subpleural, and then fine lung detail like subpleural reticulation and subpleural lines. This is a separate patient. And again, very well demarcated ground glass opacity in the upper lobes bilaterally. These scans were not on the same day because we didn't have the fortunate scenario to be able to image patients on the same day on a CT and MRI. The CTs were acquired through clinical care, routine clinical care. That means insurance paid. Whenever the CT was scheduled, they got it. If we got lucky and the patient had time to come to radiology, we got an MR that was in close proximity. These are a few days apart. So what we did was we graded these. We divided the lung into 4 quadrants and we gave them opacity scores of 1 to 4 in each quadrant based on 0 to 25%, 25 to 50% opacity, and so on. So what did we find? And this is that same patient, the 6-day interval between the images. Because this was a subset and we did by quadrant, we did find that there was concordance in detecting the opacities. So 152 out of 176 quadrants were concordant with a moderate inter-reader concordance, and the extent 91 out of 176. And it's kind of tough, if you're going to go 25 to 50 or 50 to 75, but the kappa was substantial. So that was our first assessment, and we really found moderate to substantial intermodality concordance across the board, but it's a very small cohort. It was only 22 scans that we were able to do this for. And the next thing, even if it's comparable or it's reflecting what you see on CT. What about your inter-reader reliability? If I do my ratings and Amy does her ratings and Christina does her ratings and Linda and Anna, and we have so many great chest radiologists, it has to be reliable in a sense. And not many people are used to MRI. I mean, if I ask, does anyone know how to window a lung MRI to make sure you see the ground glass opacity appropriately? Is there a default window like the liver window or a vascular window? We're not even nearing that yet. I emailed someone in Japan to ask them this question not that long ago, and they said, we'll talk. So we'll see. We'll see. But the inter-reader concordance was fair to moderate, not terrible, passable. That was aim 1. Aim 2, let's forget about our CTs. Just MRIs. Is there clinical relevance to the morphology? And why are we wondering this? This is because of the heterogeneous long COVID cohort. So these are 3 patients with vastly different presentations. This patient on the top, almost a year out post-COVID, this is what they look like. They still have opacities bilaterally and abnormal PFTs. So one would say, okay, I'm not surprised. Lung morphology abnormality, abnormal function. Then we have the middle patient, over a year away from COVID. So this study was stopped. We started retrospectively looking once we were at year 2, so September 2022. Despite these extensive opacities, this patient is asymptomatic. And then this last patient, 579 days post-COVID, while they don't have much airspace abnormality, minimally in the anterior left lower lobe, they're very symptomatic. So this was the issue with long COVID patients. They have a variety of heterogeneous presentations. So we wanted to look at the patients. And again, this was a group of patients who were not on a strict protocol. Much of the assessment was whatever was paid for through routine clinical care. So of course, we had 167 MRs and over 100 patients, but not all of them had PFTs or review of systems or St. George questionnaires in a time frame that would be relevant. And why do I say that? These post-COVID patients, at time point 1, they may have no symptoms. Time point 2, they may have symptoms. Time point 3, it may relapse. So long COVID is characterized by relapsing or persistent symptoms. And 40% of our cohort had fatigue, 40% dyspnea on exertion, and only about 10% were asymptomatic at the time point we assessed. We knew that the hospitalized patients had more severe opacities, not surprising. That's why they were hospitalized. And what was the relevance of the MR opacities? Like CT opacities, the MR opacities were associated, and these are quartiles of opacity severity. They were associated with reduced DLCO, reduced total lung capacity, reduced FVC, and increased FEV1 over FVC. So there was a physiologic correlate to the opacities on MR, but the opacities were not associated with symptoms, which was very interesting. So physiologic correlate, but not a symptom correlate. And we did this with univariable and multivariable regression analysis. So our final investigation, when we get research exams, a lot of times we put in that canned dictation, full report not to be made, images just obtained for investigation, but nonetheless, we look at our images. So here I am looking through our images through the respiratory cycle, watching this patient as she's breathing. She's symptomatic in her chart. And then suddenly you see that her breathing becomes irregular. She gasps, she pauses. And we notice this irregular breathing on so many patients. So I'm not a computer programmer. I am not a computer scientist. I am not an engineer. I did not know how to quantify it. If you asked me, I would have come up with something like, oh, well, we'll measure how much the diaphragm moves on the slice, or we'll measure the lung area. But we had resources, luckily. So we had our team develop software that would segment the lung and quantify the respiratory pattern. I'm going to show you the T2 image that corresponds to this patient. Not much ground glass opacity, minimal at the lung bases, but very abnormal breathing pattern. So most people, when they breathe on MR, the normal volunteers, it will be a regular rate, depth, and rhythm. Not like this suddenly your diaphragm depresses or suddenly you speed up and look like you're hypercapnic. So very different. So software was developed and we segmented out each lung, and basically because we had that, this is a high temporal resolution image, and limitation, I'll just start out in the beginning. It's one slice. This is one slice. It's not a global assessment of the whole lung, but that's where most of our functional assessments are right now, based on a single slice. We generated respiratory curves, and then we combined them for our analyses. And what we did was we wanted to see, does the respiratory pattern allow us to stratify patients by symptom severity? Patients are telling you something's wrong. Can we validate them? Is there something that can? And we found that there was something that could, and it was quantification of this respiratory pattern. Now, when we think about PFTs, we know for ILD that PFTs are not as sensitive as imaging. So this is kind of the great foothold we have in radiology. We can be more sensitive than the clinical assessments that are available right now. And I don't know if any of you have ever done a PFT or incentive spirometry. I did one once. They said I wasn't trying hard enough. Presumably I was 18 at the time. I think I was pretty healthy. I wasn't trying hard enough. I tried harder. I still didn't do a good job, apparently. Now, what would you prefer if you were a patient? The MR where you just get to lie down, or incentive spirometry? And if you could have a more sensitive answer, I think I know what I would choose. So we looked at various things. We created maybe 10 or 12 different metrics, and then we did tests to see which ones had the most signal. The ones that were the best were area CV. So area CV, that was the standard deviation of the amount of change in that coronal area of the lung. So that standard deviation helped stratify patients based on symptom status. And this was a monotonic increase in value between the symptomatic groups. So it moves, in step with what you would expect. And then something we called incoherence. So incoherence is the deviation from periodicity. So if you have a perfectly sinusoidal curve for your breathing, we put that as a value of 0. The further away this number for incoherence got from 0, meaning your rate, your depth, your slope of your curve is more irregular, that was more incoherent, more dysfunctional breathing. And so that was really the greatest metric that we developed. And we'll see. While this is all tested in post-COVID, the goal is not post-COVID. This was an exploratory kind of investigation, and we'll see if it works in other populations. Now, the other question that may arise, okay, so those patients with a dysfunctional respiratory breathing, well, maybe they were the ones that had the most severe airspace disease. Nope. The severity, total opacity scores were not significantly different across the sections. And, we've submitted and rejected papers that presents this data, and the criticisms are valid. There's heterogeneity in the cohort. There's different amount of time difference between, the clinical assessment and the MR. Yes. But some other research does corroborate this idea that the opacity score is not correlating with symptoms. So we'll look at some of those in a few minutes. And these are two side-by-side comparisons: an asymptomatic patient with ground glass opacities, a lower incoherence, compared to a symptomatic patient. Their lungs, no opacities, and they have higher incoherence, which means further deviation from the expected sinusoidal or periodic breathing. So this could be one of the clinical things that we do. Now, number 4, phase resolved functional lung imaging. So again, this is using the same single coronal slice, And with that non-con free breathing acquisition, you can quantify perfusion and ventilation. Once we get a little more advanced, and they're working on this at several academic medical centers, you can even do lung deformation and do regional mechanics of the lung in lobes, et cetera, even segments. Now, we tried this. It's not easy. Your signal intensity has to be good enough. So we troubleshooted and iterated. And in the end, I think we had a cohort of about 20 patients that we could ask a question and compare it to some clinical parameter. And we basically found that the ventilation perfusion did not correlate with symptoms, but it was too small of a cohort to say anything. But other people, luckily, have worked on this. So the main question is, can PreFull, that's the phase resolve functional lung imaging, distinguish patients who are symptomatic from those who are asymptomatic? This patient from this cohort from Lea et al., a lot of post-COVID patients, and they found that while no single variable differed, combined scores were higher in those with symptoms. So looking at the ventilation perfusion mismatches correlated with patients who are symptomatic. So this is interesting because they're also saying that morphology does not correlate well with the functional parameters. So the opacity, for example, doesn't correlate well, but functional parameters may correlate with symptoms. Another study in radiology in pediatric patients, and they found that VQ mismatches were worse in patients with long COVID. So healthy on the top, there aren't many defects, it's all green. That's great. That's how you want it to look on your PreFull. Then a recovered patient from COVID, they have defects or mismatches in either ventilation or perfusion. And then we get to the long COVID, and that's really a very heterogeneous presentation. So the imaging is going to give us something that the tests currently on the market don't give us. Not only are we getting a functional quantitative metric, which doctors really like, but we're also getting a visualization so we can get a regional distribution. Now, those were done at low field strengths. Functional imaging has also been done at greater than 0.55 Tesla, and similarly, they've found greater heterogeneity in ventilation with more severely symptomatic patients. And they found that this regional heterogeneity, so these patients who are symptomatic, they had dysfunctional breathing. So randomly, they would have deeper breathing or more rapid breathing. So this is a very interesting observation, and it kind of dovetails nicely with the periodicity and the incoherence idea. And of course, the next area for growth is dynamic ventilation maps, and then looking at more than one image and having a global lung map. This is the last study I'll share. And this is also an example of PreFull, and it's basically in a CTEPH patient before and after pulmonary endarterectomy. And we can see in B, this is after treatment, the degree of defects is significantly decreased. So the endarterectomy has worked and the perfusion and ventilation is improved, or actually just the perfusion in this case. So there are other populations that are basically waiting for us to study them, post-lung transplant, COPD, and CTEPH patients. So in conclusion, just like a paper, our limitations and needs is our penultimate topic. So we went through the limitations and where we need to go in terms of moving from a single slice to whole lung quantification, standardized viewing, reference signal intensity values of the lung, which we don't yet have. And of course, there's a world that we didn't discuss, like hyperpolarized gas, PET MR, diffusion imaging, et cetera. So to recap the Renaissance, maybe low field will be able to increase accessibility and applicability. I don't think it's in enough academic medical centers, or there are enough of us investigators for us to know in the lung where we can go with low field, but there is a lot of potential there. Hopefully it does hasten our clinical implementation of lung MR, and it's on us to be really creative in terms of our acquisition parameters and our post-processing so that we can really add the high performance aspect to the low field MRI. That's been the catchphrase. It's low field MRI, but it's high performance low field. And that's because of everything that we can add to it with other technology. So it's not really a standalone at all. And of course, I have to thank everyone at NYU, including the radiology and pulmonology teams who did lend their funding support in this cohort's curation. I would love to take any questions, and thank you for the invitation.